Welcome back. In this video, I'm bringing you something completely different. So in this video is a part 2 in essence, because we already published a video on 60 questions for Psych, EOR, and PANCE, in which we go question by question, covering all the results and why the wrong answers are wrong. But in this video, let's do something different. So we're going to go with 60 questions. You're going to be timed 1 minute per question, just like you will be doing your EOR and PANCE to help you prepare for those exams. So you get to time yourself. So I advise you get a paper and a pen, write down your best answer, and at the end, see how many you get correct. And towards the end, we'll go through each question individually. So these questions are brought to you by PA Study Buddy Ultimate Physician Assistant EOR Study Book, in which we cover all 57 topics from the blueprint, and it will also include 120 exam style questions where you can take them to prepare for your exam, study less, learn more, spend time with your loved ones. So we will begin here in a minute. Here is a question number 1. So I will start a timer and I will switch every minute. So here we go. Good luck. By the way, I think I'm just gonna stay silent throughout the timing so you can focus on your exam. All right, guys. So if you made it this far, congratulations. Hope that helps you with the timing and so you can prepare better. And let's go and answer all these questions individually. And before doing that, let me introduce you to the PA Study Buddy EOR study book for psychiatry, where you will find another 120 exam style questions just like this. And we will cover all 57 topics that are listed in the blueprint. So that book is available on Amazon. Check it out. It will help you save time. I struggle with the EORs because I had to use several different sources, such as study guides that others prepared, that I prepared, plus the school material, PANCE Prep Pearls, XYZ. This is book that organizes all of that into the one unit. So do check it out. Let me know what you think. So let's begin with the review of the questions. So the question one, another thing that I found very helpful for me is when it comes to test taking strategies, I used to really struggle, especially with the long stem. I would read a thing. By the time I get to the answers, I would forget half of the things that were in there. So what I do now is I will read the last question first. Oops. And basically see what the question is asking me. Then I will skim through the answers, knowing what I know about each one, and then I will start reading the stem. So, what is the most likely diagnosis? Schizophrenia, schizophreniform disorder, delusional disorder, schizoaffective disorder. So, a 19-year-old college freshman is brought by the friends for unusual behavior over the past 4 weeks. So, the time frames within psych is huge because that differentiates one condition from the other. So, knowing the time frames, it will save you time in studying and it will help you pick the right answer most of the time. So, over the past 4 weeks, he has been socially withdrawn, expressing odd beliefs that the government implemented a chip in his brain. That's fun. He also reports having voices commenting on his actions. There is no history of mood disorder or substance use. Physical exam and labs are unremarkable. What is the most likely diagnosis? And the correct answer is schizophreniform disorder. So the schizophreniform disorder duration will be between 1 and 6 months with psychotic symptoms. Over the same patient, if they said it was for 7 months, that would qualify as a schizophrenia. And delusional disorder presents without any hallucinations or disorganized speech. So that one is out. And then a schizoaffective disorder requires mood episodes concurrent with psychosis. And in this question stem, there was no issues with the depression. So giveaway in this question was to think about that time frame. Psychosis with 1 to 6 months equals schizophreniform. Greater than 6 months is schizophrenia. Question number 2. Which diagnosis best explains his behavior? Antisocial conduct, kleptomania, narcissist. So 45-year-old man is brought in after being caught shoplifting. He admits he has stolen hundreds of times, often for a thrill rather than need. He shows no remorse and has a history of lying, fighting, and reckless driving since adolescence. What is this? Well, this is an antisocial personality disorder because he has disregard for others, there's criminality, and he absolutely has no remorse. And he's older than 18 years old. So that is antisocial personality disorder. A conduct disorder would be the same stem, but the patient will be under the age of 18. Kleptomania is still an object impulsively without use or monetary value, not criminal pattern. And a narcissist is just arrogance and need for admiration. There's no criminal conduct. So the giveaway, antisocial adult conduct disorder with no remorse. Question number 3. Which is the best initial treatment? SRI, benzos, cognitive behavioral therapy, or buspirone. So a 31-year-old woman presents with 7 months history of daily worry about her health, finances, and job performance. She says she cannot stop worrying. So constant worrying should point you in the direction of generalized anxiety disorder. It's greater than 6 months, so that qualifies as GAD. So right there we know she's having generalized anxiety disorder, and basically the question is, what is the best initial treatment for this? She's also having insomnia, restlessness, muscle tensions. No panic attacks or psychosis are reported, so that is important. So for generalized anxiety disorder, we know the first line pharmaceutical therapy is SNRIs, so you can select that and move on to the next question if you're pressed for time during your exam. Benzos are useful for short term, but they're not a first line. CBT is effective, but psychotherapy is often started first. And you can do CBT if it's more moderate severe cases. And a buspirone option if SSRI fails or it is contraindicated. So giveaway for this question, we're dealing with general anxiety disorder, pick SSRI. All right. So which is the most likely diagnosis again? So throughout your didactic here, you will see the test creator have this deal where they ask a lot of the questions such as what is the most likely diagnosis, what is the side effect of this medication, what is the next best in treatment, what is the most likely imaging finding, so forth. So knowing all that high yield information will significantly improve your test taking scores and ability to like pick the right answer fast if you're pressed for time. So, which is the most likely diagnosis? Panic disorder, general anxiety, specific phobia, somatic symptom disorder. A 23-year-old man presents with a recurrent episode of intense fear, accompanied by palpitations, sweating, trembling, and shortness of breath. He worries constantly about having another attack and avoids exercise because he fears triggering one, which is the most likely diagnosis. Well, these are typical signs of panic disorder because he's having these recurrent panic attacks and he's persistently worried about them, and there's also avoidance. So in general anxiety disorder, there will be excessive worry, but there's no such thing as sudden attacks. So general anxiety disorder is a wrong answer. Specific phobias will be tied to one object or situations, and there will be no random attacks. And somatic symptom disorder, you will see physical symptoms will dominate, but there's also, again, no panic episodes. So fear of the fear itself, panic disorder. Avoidance, panic disorder. Which is the most likely diagnosis? Body dysmorphic disorder, somatic symptoms, illness anxiety, and OCD. A 29-year-old woman has 8 months of preoccupation with the scar on her face. She spends hours daily checking mirrors and avoids social events. On exam, the scar is barely visible. So this is a classical presentation of body dysmorphic disorder because they're going to be obsessed with a minor or imagined defect. In that case, they may not even have anything, but they just think they do. This is highly stressful to the patient, and it's something you will definitely see during your psych rotations. So somatic symptoms will be excessive worry about the real symptoms, illness anxiety, fear of having a serious disease, and OCD is intrusive thoughts plus rituals. It is not limited to appearance. So giveaway if the patient is checking mirrors, if they have imagined defect, that always equals body dysmorphic disorder. Question number 6. Which substance is most likely responsible? Cannabis, LSD, opioids, or alcohol? A 34-year-old man is brought to the ER after intoxication at the party. He is aggressive, hypertensive, hyperthermic, and reports seeing flashing colors. On exams, pupils are dilated and he is sweating. This is a case of LSD, where they will present with the classical hallucinations, causing visual hallucinations, hyperthermia, and they will have pupil dilation. So, visual hallucinations, pupil dilations, you should be thinking LSD. Cannabis, they'll be euphoric. They will have conjunctival injection. They will have increased appetite, the munchies, and no hallucination will be presented with cannabis. So with use of opioids, they will have pinpoint pupils. That's the one big differentiator from LSD. With opioids, they'll have the pinpoint pupils. They will also have the respiratory issues such as depression, and they will have sedation. And alcohol will be central nervous system depression, and there will be no hallucinations. So hallucinations plus dilated pupils, think hallucinogens such as LSD. I hope you guys find these videos really helpful. It takes a lot of time to create this, but if it helps only one person, it's worth making it. So, which is the most likely diagnosis? Conduct disorder, ODD, ADHD, antisocial personality. A 16-year-old boy is defiant toward teachers, deliberately annoys peers, and argues with his parents. He has not committed any crimes. He has not destroyed any properties or shown any cruelty. School grades are declining due to behavioral issues, and this is a case of oppositional defiant disorder. These patients will be under the age of 18. They'll be argumentative, defiant, but no serious violations. So a conduct disorder will have more severe symptoms with aggression, theft, and cruelty. ADHD is just inattentive, hyperactive, no hostile defiance, and antisocial only diagnosed after the age of 18. So a defiant kid with no cruelty, no destroying property, just teenager talking back to his parents, talking back to the teachers, that is ODD. Question 8. Which is the most likely diagnosis? Anorexia, bulimia, binge eating disorder, borderline personality disorder. A 21-year-old woman reports recurrent binge eating following by vomiting and excessive exercise. A BMI is 22. So right there, when you see a BMI of 22, you can exclude anorexia because anorexia will have a way lower BMI. Labs show hypokalemia, likely from the vomiting, and metabolic alkalosis, which is the most likely diagnosis. Well, this is a classical presentation of bulimia nervosa. These patients will have normal BMI, will report binge purge eating, and then they will have electrolyte issues due to the vomiting. Anorexia will require the low body weight, low BMI. Binge eating is binge without a purge, and borderline may have impulsivity but not eating specific. So normal weight plus binge purge equals bulimia. Question 9. Which is the most likely diagnosis? Paranoid, schizophrenia, delusional disorder, schizotypal personality disorder. A 28-year-old man believes co-workers are plotting against him despite no evidence. He avoids social gatherings, citing fear of persecution. He has no hallucinations or mood disturbance. This is a classical presentation of the paranoid personality disorder. So he has a long-standing suspiciousness and there is no psychosis reported. So he's suspicious about his co-workers. He has no mood disturbance. He has no hallucinations. Presentation of paranoid 100%. Schizophrenia will have psychosis, non-reported here. Delusional disorder will be the fixed delusion, but here it's a diffuse suspiciousness, not only delusion. And schizotypal would be, I believe, eccentric behavior beyond just paranoia. So, pervasive distrust without psychosis, paranoid personality disorder. Which agent is most appropriate in acute management? Naloxone, flumazenil, activated charcoal, and methadone. A 48-year-old man is found unresponsive after taking a large dose of diazepam. He has slurred speech, ataxia, and drowsiness, but stable vital signs. Which agent is the most appropriate in acute management? And acute management for benzodiazepine overdose would be flumazenil. And this is for benzodiazepine antidote. And the way I remember this, I always create little stories to help me remember things, is flu in flumazenil treats the benzo issues. So when I got the flu, you got rid of the benzo issues. So flu, if you anything to do with benzo and an overdose, just think if I had a flu, I would fix this. Flumazenil, that's your answer. Naloxone is for opioids, activated charcoal, rarely useful unless recent ingestion, and methadone is used for opioid dependence, not benzo overdose. Giveaway benzo antidote, flumazenil, but watch for the risk of the seizure. Which treatment is the first line? Atomoxetine, methylphenidate, behavioral therapy only, and bupropion. A 7-year-old boy is disruptive in class, unable to sit still, blurts out answers, and loses items daily. Symptoms occur at home and school. This is a treatment for ADHD. This child obviously has ADHD. ADHD is needed to be in two different settings, such as home and school. He is disruptive, so methylphenidate is a stimulant. It's a first-line treatment for ADHD. Atomoxetate is a non-stimulant. It's a second line. Behavioral therapy is helpful in adjunctive to the medication, but is not a first line. And bupropion is off-label option. It's not a first line. So school-aged ADHD, think of stimulants first. Which is most likely diagnosis? Delusional disorder, schizophrenia, borderline personality, schizoaffective. A 40-year-old woman believes a celebrity is in love with her despite never meeting him. That sounds like a lot of fun. She stalks him online but functions normally otherwise. No hallucinations, mood episodes, or disorganized speech are reported. This is a classical case of delusional disorder. Isolated fixed delusion, intact function. Schizophrenia will require hallucinations. She had none. Borderline will be instability in relationships and mood, no fixed dilations. She hasn't even met this person, so there's no relationship. And the schizoaffective will be psychosis plus mood episodes. So one delusion, intact function equals delusional disorder. Which is most likely diagnosis? Illness, anxiety disorder, somatic, factitious, or malingering. So a 26-year-old woman has repeated ER visits with abdominal pain. She demands extensive testing. You may see this during your ER visits, and these patients you will remember. This is something I seen couple during my ER visit, and I still remember them today clearly. And it's been like what 7 years? Yeah, this is wild. You will see this. She demands extensive testing, which always comes back normal. She says something is seriously wrong, despite reassurance, which is the most likely diagnosis. So this is a case of somatic symptom disorder, real distress over symptoms despite negative workup. Illness anxiety, they will be preoccupied with disease, but they will have no symptoms. And factitious, they will be intentional for medical attention. Malingering will be intentional for external gain. And in this case, you have symptoms that cause distress, not faked, and this is somatic symptom disorder. Which is most likely diagnosis? Female sexual interest arousal disorder, hypoactive sexual desire disorder, sexual aversion disorder, somatic symptom disorder. A 35-year-old woman presents with a sexual dysfunction. She reports little desire and difficulty with arousal for the past 8 months, leading to relationship stress. Medical causes and medications have been excluded, which is the most likely diagnosis. So this is a good case of female sexual interest and arousal disorder, persistent lack of arousal disorder causing the distress in the relationship. Hypoactive sexual desire disorder is most male specific. Sexual aversion, avoidance due to the fear or disgust, not lack of arousal, and somatic symptoms unrelated to the stem. So, given this stem is we are dealing with a 35-year-old female, not a male. Interest and arousal disorder if both low desire and poor arousal. Low desire, poor arousal, female sexual interest arousal disorder. Which treatment is the most urgent? IV glucose, IV thiamine, disulfiram, and naloxone. A 52-year-old man with a long-standing alcohol use disorder presents with confusion, ataxia, and ophthalmoplegia. Which treatment is most urgent? So this would be IV thiamine, because IV thiamine in alcoholics will prevent this patient from developing Wernicke encephalopathy or worsening of it. IV glucose is given after thiamine. Disulfiram for long-term abstinence. It's not for acute treatment. And naloxone is for opioids. It's not for alcohol. So giveaway, he's confused. He has ataxia. He has eye signs. This is alcohol use disorder. So give them thiamine before glucose. They could also ask you in which order is this medication needed to be given. So they could have said IV thiamine followed by IV glucose. That would have been the correct answer as well. Which diagnosis fits best? Bipolar 1, bipolar 2, cyclothymic disorder, borderline personality disorder. Oh, by the way, guys, if you like these questions, I'm making a video on each one of these diagnoses and they'll be on my channel. So far, there's bipolar 1, bipolar 2, but I intend to make all of these videos. So if you are studying, they're about 5-10 minute long videos and you'll find them super helpful. So 27-year-old woman presents with alternating periods of elevated mood and energy lasting about 5 days. That is important. So in order to differentiate bipolar 1 from bipolar 2, it is dig fast mnemonic, and we're looking for 7+ days of symptoms to be bipolar 1. 4 or 5 days but not 7 is bipolar 2, and followed by a week of sadness and low motivation. She has never experienced full mania. So if she never experienced full mania, bipolar 1 is off the chart. So you can rule that one out. During the up phases, she feels more social, sleeps less, but still functions at work. Which diagnosis fits best? This is a clear case of bipolar 2 disorder. And the way I remember bipolar 2, the 2 stands for two different moods needed to diagnose the bipolar 2. And two different moods are hypomania and depression. So she has elevated mood for 5 days, qualifies as hypomania, and then she has down phase, which she is feeling depressed. So those two, 5 days, that's hypomania plus depression equals bipolar 2. Bipolar 1 must have one manic episode. Cyclotimic, this will be only mood swings that are going to last for greater than 2 years. And borderline, it's mood instability tied to relationships, and it's not a discrete episode. Which is most likely diagnosis? Panic disorder, generalized anxiety, social anxiety, specific phobia. A 20-year-old college student avoids public speaking due to the intense fear of embarrassment. She avoids presentation and social gatherings. Though she functions well academically otherwise, she experiences sweating, trembling, and nausea when asked to speak in class. This is a classical case of social anxiety disorder. Intense fear of social performance situation, fear of being judged equals social anxiety. Give this patient a propranolol and she'll do just fine for her speech. So panic disorder is recurrent unexpected attacks, not present here, not tied to the social events. General anxiety disorder is all about worrying for many in many areas, not just the social performance. And specific phobia would be a fear that is restricted to the object or situation, not social interactions. So now you can see how knowing all these little bits about each one of these conditions can help you pick the right answer. Which is the most likely diagnosis? MDD, persistent depressive disorder, dysthymia, cyclotimic, or adjustment disorder? A 50-year-old man presents with a depressed mood, anhedonia, and a low energy for the past 3 years. So right there, I know we're dealing with persistent depressive disorder because we need symptoms to last for greater than 2 years. So he says he has always been a gloomy person and cannot recall feeling normal. Symptoms have never fully remitted for more than 2 months, which is the most likely diagnosis. So this is a good case of persistent depressive disorder. He is dealing with depressed mood for greater than 2 years, and there was no symptom-free period that is greater than 2 months. So anhedonia should always tip you in the direction of persistent depressive disorder. An MDD, you'll see the episodes that last greater than 2 weeks, but not necessarily chronic. Cyclotimic would be mood fluctuation. It's a not constant depression. That's what helps to differentiate cyclotimic disorder for persistent depressive disorder, dysthymia. Dysthymia is just constantly chronic depression, and cyclotimic, that cyclo is the cycles, so mood fluctuations. And adjustment disorders occurs within 3 months of a stressor, resolving within 6 months. So that one is out. Chronic gloom for greater than 2 years, dysthymia. Which is the most likely diagnosis? GAD, OCD, schizoaffective disorder, illness anxiety disorder. A 39-year-old woman describes recurrent intrusive thoughts about harming her child, which she finds distressing. She spends hours each day praying to neutralize these thoughts. She recognizes they are irrational but feels compelled to perform rituals, which is the most likely diagnosis. So, this is a case of OCD, intrusive obsessions with compulsions to reduce anxiety. General anxiety disorder, again, you will see excessive worry, not ritualistic compulsions. Schizoaffective, there'll be presentation of psychosis plus mood disorder, not just obsessions. So that one is out. And illness anxiety will be preoccupation with illness, not intrusive thoughts. So if you see obsessions plus compulsion equals OCD. Which is most likely diagnosed? Somatic symptoms, illness anxiety, factitious, and body dysmorphic. A 32-year-old man presents with excessive preoccupation with developing a serious disease despite normal exams and tests. He frequently checks his body and visits multiple physicians. He has few physical symptoms but fear having a cancer, which is the most likely diagnosis. So this is illness anxiety disorder because he's preoccupied with having a serious disease with the minimal to no symptoms. Somatic symptoms will be real symptoms dominate, but not fear of disease. Factitious is just intentional fagging for a medical role, and a body dysmorphic will be obsession with appearance defect. So body dysmorphic will be the one checking mirrors and so forth. So health anxiety without symptoms, illness anxiety disorder. Which is the most likely diagnosis? Alcohol use disorder, alcohol intoxication, alcohol withdrawal, and sedative hypnotic use disorder. A 41-year-old man presents with a history of repeated arrests for drunk driving. He drinks every evening, has blackouts, and has difficulty stopping despite job and relationship issues. On exam, tremors are noted, which is the most likely diagnosis. Well, this is a clear case of alcohol use disorder. He has impaired control, continues use despite the harm. Intoxication would be acute effects, not a chronic pattern, and withdrawal will see the tremors, but also seizures and hallucinations after stopping. So sedative hypnotic will be the similar presentation, but here history is alcohol specific. So failure to cut down plus consequences equals alcohol use disorder. What complication is most concerning? Pulmonary embolism, MI, hypoglycemia, or stroke? A 26-year-old man is brought to the ER after collapsing at the club. He is diaphoretic, hypertensive, and has severe chest pain. Exam shows dilated pupils and tachycardia. Urine tox is positive for cocaine. What complication is most concerning? So when it comes to the cocaine, you should always be thinking about myocardial infarction. So cocaine equals MI. Cocaine causes coronary vasospasm, leading to ischemia. Pulmonary embolism is not linked to the stimulus intoxication. Hypoglycemia is not typically seen with cocaine. And stroke is positive, but MI is the most common acute complication. So giveaway, if you think cocaine, think vasospasm, think MI risk. Which is most likely diagnosis? Histrionic, borderline, narcissistic, bipolar 2. A 43-year-old woman reports chronic instability in relationship, intense fear of abandonment, mood swings, impulsive spending. She has a history of self-harm, which is the most likely diagnosis. So this is a patient with difficulties in her relationship, impulsive spendings, chronic instabilities. She's also harming herself. So this is a classic presentation of borderline personality disorder. These patients will have that unstable relationship, impulsivity, self-harm, and a fear of abandonment. So histrionic, this will be attention seeker, there's no self-harm, narcissistic, grandiosity, lack of empathy, and then bipolar 2, you will see the mood episodes, not persuasive instability. Giveaway, cutting and abandonment fears, borderline personality disorder. Which is the most likely diagnosis? Voyeuristic disorder, pedophilic, exhibitionistic, fetishistic. Man, these are all some crazy names. A 36-year-old man has recurrent intense sexual urges toward prepubescent children. He feels guilt but has acted on them by viewing child pornography. He denies psychosis, which is the most likely diagnosis. Well, this is a clear case of pedophilic disorder, sexual arousal from children, persistent, and he has acted upon it. So voyeuristic would be watching unsuspecting others undress. This will be, people peeping and stuff, peeping toms. Exhibitionistic will be the one exposing their genitals to the strangers, and the fetish disorder is arousal from non-living objects. So sexual urges toward children, pedophilic disorder. Which is most likely diagnosis? Somatic, factitious, malingering, illness, anxiety. A 30-year-old woman presents with recurrent headaches. She admits to intentionally exaggerating symptoms and falsifying test results to gain medical attention. No external reward identified. With no external reward identified, you can basically rule out malingering. This is a case of factitious disorder because she's deliberately showing her illness for psychological benefit, which is in this case, they just want attention. So somatic symptoms will be symptoms present, she has none. Illness anxiety will be preoccupation with having a disease. So giveaway, faking for care or attention, factitious disorder. Which is most likely diagnosis? Panic, specific phobia, social anxiety disorder, PTSD. A 22-year-old college student presents with a chest tightness and sweating when she sees dogs. She avoids parks and refuses to visit friends with pets, which is the most likely diagnosis. Well, this is a clear case of specific phobia. There's excessive fear of an object or situation, in this case, that's pets, leading to avoidance. So, panic disorders will be attacks occur unexpectedly, not just with triggers. Social anxiety will be fear of being judged, not dogs. And PTSD requires trauma history. Dog fear equals specific phobia. Which is most likely diagnosis? Schizophrenia, schizoaffective disorder, schizophreniform disorder, and brief psychotic disorder. A 54-year-old man has auditory hallucinations and disorganized behavior for 2 months. His family reports functional decline. He has no mood episodes or substance use history, which is the most likely diagnosis. Well, this is a case of schizophrenia. Schizophreniform disorder. So schizophreniform is hallucinations and disorganized behavior, but symptoms will last 1 to 6 months. The same stem, if they said patient was dealing with this for 7 months, will classify it as the schizophrenia. So since it's less than 6 months, 1 to 6 months, schizophreniform, greater than 6 months, schizophrenia, and schizoaffective disorder will require psychosis plus mood disorder, which he does not have in the stem, and brief psychotic would be less than a month. So time frame again, it's the key factor in picking the right diagnosis here. So psychosis lasting 1 to 6 months, schizophreniform. Which is most likely diagnosis? ODD, conduct disorder, antisocial personality, intermittent explosive disorder. That one sounds fun. A 17-year-old boy is caught stealing cars and setting fires. So he's under the age of 18. So conduct disorder is your likely diagnosis because he's stealing and setting fires. He's being criminal under the age of 18. Oppositional defiant disorder is out because he's doing things that are out of the norm. And antisocial personality disorder would be diagnosed over the age of 18. And intermittent explosive disorder is a sudden aggression, not persistent pattern. So this is somebody who just like explodes, just blow up, gets mad, but it's not constant, it just happens. So, setting fires, stealing cars under 18, conduct disorder. Aggression plus crime in youth equals conduct disorder. Which is the most likely diagnosis? Fetish, voyeuristic, exhibitistic, and sexual machinism disorder. A 38-year-old man reports repeatedly watching unsuspecting women undressed through the window. Right there, you have diagnosis of voyeuristic disorder, arousal from observing unsuspecting individuals. Fetish is from arousal from the object. Exhibitistic, they want to be exposing themselves. And masochism, arousal from being humiliated or hurt. Peeping Tom, voyeuristic disorder. Which is the most likely diagnosis? Acute stress, PTSD, general anxiety disorder, panic disorder. A 30-year-old woman presents with intense fear, flashbacks, and nightmares related to her car accident 4 months ago. That's the key. Because her symptoms are lasting greater than 1 month, she's having flashbacks and nightmares as a case of PTSD. Um, Acute stress will last the same stem. If they said 3 weeks, that would classify as acute stress. So over 1 month, think PTSD. Less than 1 month, trauma, acute stress. General anxiety disorder will be worries, no trauma specific. Then panic disorder, it is not trauma triggered. So trauma greater than 1 month, PTSD. Which is most likely diagnosis? Bipolar 1, bipolar 2, cyclotimic, and schizoaffective. A 25-year-old man is brought by family due to erratic behavior. For the past 2 weeks, he has had decreased need for sleep, precious speech, and grandiosity ideas about starting a global company. He's currently irritable and attempted to buy expensive equipment with little money. No substance use is reported. Family's history is notable for depression in his mother. What is the likely diagnosis? Well, this is a clear cut of bipolar 1. The symptoms are lasting greater than 7 days. He is having a manic episode and often severe with impairment. So bipolar 2 would be no full mania, only hypomania plus depression. Cyclotimic would be the cycling mood swings for over 2 years, and a schizoaffective will need psychosis plus mood, which is not described here. So full mania equals bipolar 1, even if the depression never occurred. So if patient presents with a full-blown mania, drop it, bipolar 1, select and move on to the next question. What is the best next management step? Switch to clopidogrel immediately, restart SSRI and titrate to higher therapeutic dose, add antipsychotic immediately, and electroconvulsive therapy. All right. So 34-year-old woman presents with a compulsive hand washing up to 50 times daily. She spends 3 hours per day scrubbing her skin, leading to excoriations. So we can see this is OCD. She recognizes her behavior is excessive but cannot stop. She previously tried fluoxetine for 2 weeks, so she has tried SSRI but quit after no benefit. So the best case for OCD, it would be to restart SSRI and titrate. So they usually need to be treatment for about often greater than 12 weeks. The clopidogrel is the second line after the SSRI trial. Antipsychotics could be augmented only if resistant to the SSRIs, and ECT is used for severe depression or catatonia, not for OCD. So OCD equals high dose, long duration SSRIs before switching meds. Which symptom domain best explains his current presentation? Positive, negative, cognitive, mood. A 40-year-old man with chronic schizophrenia is brought in for worsening apathy, flat affect, and social withdrawal. So these are all negative effects pointing to negative symptoms within schizophrenia. He denies hallucinations or delusions, which would qualify as positive symptoms. He has been adherent to risperidone. Labs and tox screen are normal. So this is a classical presentation of the negative symptoms, which are flat affect, social withdrawal, anhedonia, and apathy. Positive hallucinations, delusions, disorganizations. Cognitive would be working memory, attention deficits, and mood would be depression or mania, not core schizophrenia. So flat affect plus withdrawal equals negative symptoms. Which is the most likely diagnosis? Major depressive, bipolar 1, bipolar 2, or cyclotimic. A 29-year-old woman presents with a depressed mood, insomnia, and anhedonia for 3 weeks. She describes episodes in the past where she had increased energy and a little need for sleep for 3 days, but never impair her function. So no functional impairment, no full mania, bipolar 1 is out. This is a case of bipolar 2. Remember, bipolar 2, 2 stands for two different moods. In this case, there's hypomania and there is depression. So no marked impairment, about 4 days, a lot worth of symptoms, plus depression, bipolar 2. MDD, there's no hypomania present, and cyclotimic will require symptoms to last greater than 2 years. Hypomania plus depression equals bipolar 2. Which treatment offers the best long-term outcome? Short-term benzos, cognitive behavioral therapy, antipsychotic, and prazosin. A 46-year-old man presents with recurrent nightmares and flashbacks after surviving a warehouse fire 8 months ago. He avoids enclosed spaces and feels constantly on guard. He drinks heavily to numb memories. Which treatment offers the best long-term outcome? So for a long-term outcome, you always should be thinking CBT. So CBT with exposure, cornerstone of PTSD management. Benzos, they're not recommended. They have risk of dependence. Antipsychotics only in severe refractory cases. And prazosin is used for helpful for nightmares, but is not comprehensive and it's not for long term. So PTSD, trauma-focused CBT plus SSRI, prazosin is only given for nightmares. Which is most likely diagnosis? Schizoid, avoidant, schizotypal autism. A 16-year-old boy is seen for a poor school performance. His parents describe him as a loner who prefers solitary activities and shows little interest in friendships or romantic relationships. He is indifferent to praise or criticism. No hallucinations or delusions are reported. This is a clear-cut case of schizoid personality disorder. Schizoid people, they're going to be detached, they're going to prefer to be alone, and they're just indifferent to your feedback. They don't care if you praise or criticize. Avoidant personality disorder, they will be the ones who are avoiding due to the fear of rejection, but they will not be indifferent to the judgment. And a schizotypal, those are your odd beliefs or magical thinking people, and autism will be the language behavior deficit starting early childhood. So indifference plus solitary lifestyle, schizoid personality disorder. Which treatment is the most helpful? Frequent reassurance with extensive testing, empathetic regular visits with limited workup, confrontation about malingering, and antipsychotics. So, 35-year-old man presents with a frequent ER visits for chest pain. Workup including EKGs and troponins are normal. He insists something is wrong with his heart and requires repeat testing. He does not fabricate symptoms intentionally. Which treatment is most helpful? So, the most would be helpful actually to schedule him for regular scheduled visits, minimize unnecessary testing, and builds trust. So, A is extensive testing reinforces anxiety. That would be wrong. Malingering is external gain is absent, and antipsychotics is not indicated. Somatic symptom disorder, structured visits, not endless tests. Which diagnosis is correct? Bipolar 2, cyclotimic, persistent depressive disorder, schizoaffective. A 22-year-old woman presents with alternating episodes of mild depression and elevated mood with increased energy. Symptoms have occurred for over 3 years without symptoms-free interval for greater than 2 months, but never meet full criteria for hypomania or major depression. Which diagnosis is correct? Well, if there's no hypomania, there's no bipolar 2. If there's no major depression, you can rule out persistent depressive disorder. And cyclotimic fits this perfectly because this patient is dealing with it for 3 years. And requirement for cyclotimic disorder is greater than 2 years of fluctuating subthreshold hypomanic and depressive symptoms. So that cycling of the moods for greater than 2 years in cyclotimic. And then schizoaffective will require, of course, for any schizo stuff, schizoaffective will be psychosis plus mood, which is not present in this stem. So 2 years of mood swings, not full criteria, think cyclothymia. What is the best initial management? Outpatient fluoxetine, family-based therapy, hospitalization with nutritional stabilization, and group psychotherapy. A 30-year-old woman presents with a binge eating and purging. She reports irregular menses, a BMI of 16. BMI of 16 should make you think of anorexia right away. Lanugo hair and bradycardia. Labs reveal hypokalemia. What is the best initial management? Well, for this patient, they should be hospitalized because their BMI is less than 18.5 and they have electrolyte disturbance, so they need to be hospitalized to talk about nutrition, get their electrolytes in order, and so forth. Fluoxetine is useful in bulimia, but not first line in unstable anorexia. Family therapy is for outpatient management for stable patients, and group therapy is supportive but is not an initial step. So, unstable vitals plus low BMI, admit for refeeding. Which medication would best support smoking cessation? Bupropion, disulfiram, acamprost, and methadone. So we know methadone is out because that's for opioids. This is for quitting smoking, and you can pick bupropion right away without even reading a step. So Wellbutrin is well prescribed for smoking cessation, helps reduce craving, useful in tobacco cessation. Um, the sulfurman is for alcohol aversion. Acamprosate is alcohol relapse prevention, and methadone is for opioids. So the only one that is related to tobacco here would be the Wellbutrin. Think B for budding out. So whenever I think about like what medication helps people quit smoking, I say think B for budding out. But throw that cigarette away. Budding out, B, and just look for bupropion. Bupropion is for tobacco. They can actually get really creative and ask in a question stem, which of the following medication side effects would be in order to be discussed, asking the Wellbutrin is well known to decrease the seizure threshold. So they could list a seizure threshold and ask which of these medication is known to cause seizure threshold as well. So bupropion would be answer as well. Which is most likely diagnosis? We're almost done. 2/3 down. Histrionic, borderline, narcissistic, antisocial. A 37-year-old woman reports intense need for admiration. Right there, I can pick histrionic and move on. Exaggerated her achievements and becomes enraged when criticized. She shows little empathy for coworkers. Oh, I'll take that back. So she shows little empathy for coworkers and often exploits them for promotions. Now we're dealing with narcissistic. So sometimes even I think I have the right answer within a sentence, but when I read the rest of the stem, sometimes I correct myself. So She needs admiration. So histrionic would be seeking attention, but they would not use others. They would not have any empathy. So yeah, this stem points to narcissistic personality disorder. Histrionic, they're just going to be seeking attention. Borderline, they're going to be relationship issues, black or white, nothing in between. They could be harming themselves. Now that I mentioned this stem, antisocial personality disorder, disregard for laws or rights. So grandiosity plus no empathy, narcissistic personality disorder. I almost tripped myself on this one. This was great. Which is the most likely diagnosis? Sexual masochism, fetishistic, exhibitionistic, and voyeuristic. Man, I'm struggling with these words. A 30-year-old man presents with a history of recurrent sexual fantasies involving being tied up and humiliated. So right there, you can tell this is a sexual masochism disorder because he gets arousal from being humiliated or bonded. Fetishistic, they're going to be talking about objects. Exhibitionistic, they're going to be exposing their genitals. And voyeuristic, they'll be watching others. Enjoying being humiliated, masochism. Which deficiency is most likely? Thiamine, vitamin B12, folate, vitamin D. A 19-year-old woman is brought after confusion and seizures. She has been using whippets at parties for several months. Neuroexam shows ataxia and peripheral neuropathy. Which deficiency is most likely? The correct answer will be vitamin B12. Nitrous oxide inactivates B12, causing neuropathy and neurosymptoms. So if patient presents with any kind of neurosymptoms such as neuropathy, you should be thinking B12 first. Thiamine is used for Wernicke encephalopathy, seen with alcohol use disorder, not in this stem. Folate is megaloblastic anemia without neuropathy. Vitamin D would cause bone disease and not neuro. So whippets, nitric oxide, B12 deficiency. All right, what is the best next step? Continue clozapine and repeat labs in 1 week. Discontinue clozapine immediately. Switch to risperidone without stopping clozapine. No change required. So, a 45-year-old woman with schizophrenia has been stable on clozapine for 6 months. During a routine visit, the lab shows white bell count of 2000, ANC of 800, and she is asymptomatic. What is the best next step? The next best step would be to stop clozapine because her ANC is less than 1000, which is a granulocytosis risk. So you would not continue. That would be dangerous because her ANC is too low. Overlap is never safe, so you must discontinue one to start another. And ANC this low requires immediate action. So ANC less than 1000, you should be thinking a granulocytosis risk. Clozapine plus ANC less than 1000, stop that medication immediately. Which neurotransmitter system is most implicated? Dopamine, GABA, serotonin, norepinephrine. A 32-year-old man reports repetitive checking of door locks for hours nightly. He believes disaster will occur if he doesn't. His ritual interferes with sleep and work. This is a serotonin and is seen with OCD. So, OCD is strongly linked to serotonin pathways. Dopamine implicated in schizophrenia, GABA benzodiazepine effects, not OCD, and norepinephrine is linked to panic anxieties, no OCD. So OCD equals serotonin and give that patient SRI. Which neurotransmitter system is most implicated in his condition? Dopamine, GABA, serotonin, norepinephrine. So let's see if you remember things from the last question. A 32-year-old man spends 2 to 3 hours nightly checking door locks, stoves, and windows, fearing that his apartment will catch fire or be burglarized if he doesn't. He recognizes these behaviors as excessive but feels unable to stop them. His ritual interferes with sleep and work. So again, we're dealing here with serotonin dysregulation, OCD once again, very similar to the last question, and this would be serotonin is strongly linked with OCD. Dopamine, schizophrenia, GABA would be anxiety, and norepinephrine would be also with panic and general anxiety. OCD, serotonin, SRI, first line treatment. Which personality disorder is most likely? Borderline, histrionic, narcissistic, avoidant personality disorder. A 25-year-old woman reports a long history of unstable relationships. That right there makes me think this is borderline. Intense fear of abandonment and mood swings. She describes impulsive behavior such as binge eating and reckless spending. On multiple occasions, she has engaged in self harm. So, self harm, unstable relationships, bipolar, borderline personality disorder. That is a clear stem. Um, You'll see the hallmark of emotional instability, fear of abandonment, and self-harm. Histrionic, they're going to be dramatic, they're going to be attention seekers. Narcissist is all about grandiosity, and avoidant is a social inhibition of fear or rejection. There's no impulsivity or self-harm seen. So, emotional dysregulation, impulsivity, self-harm, borderline personality disorder. Which diagnosis best fits his presentation? Delusional, schizophrenia, paranoid, schizoaffective. A 40-year-old man presents with a persistent, fixed belief that coworkers are conspiring against him. He denies hallucinations, right there, schizophrenia is out, mood symptoms, and has maintained normal functioning otherwise. These delusions have been present for over a month. He has no history of substance use or prior psychiatric illusions. Which diagnosis best fits? And that would be delusional disorder. So, non bizarre delusion fixated for greater than a month without psychotic symptoms. Schizophrenia requires hallucinations. Paranoid personality is pervasive distrust but no fixed delusions. And schizoaffective requires concurrent mood episodes. Isolated, not bizarre delusion equal delusional disorder. Which is the most likely diagnosis? MDD, persistent depressive, bipolar 2, cyclotimic. A 28-year-old man presents with a depressed mood, anhedonia, insomnia, decreased appetite, and guilt for 3 months. So 3 months right there, cyclotimic disorder is out because it needs to be greater than 2 years. Persistent depressive disorder also requires symptoms to be greater than 2 years, so that one is out. And he denies any history of mania or hypomania. If there's no hypomania, there's no bipolar 2 disorder. Right there, you can tell this is major depressive disorder. So 3 months of worrying. Labs are normal. No psychotic features. No mania. No hypomania. Um, they cause significant impairment of work and social functioning. You're dealing with MDD. Symptoms are greater than 2 weeks of major depressive symptoms without hypomania. So again, persistent depressive disorder requires symptoms of 2 years of milder symptoms. Bipolar 2 requires hypomanic episode, and cyclotimic is that cycling depressing symptoms for greater than 2 years. So greater than 2 weeks of full depressive symptoms without hypomania equals MDD. Which symptom is most characteristic of acute intoxication with this substance? Psychomotor retardation, hypersomnia, tachycardia, bradycardia. A 31-year-old man presents to the clinic reporting daily cocaine use for a past month. He reports episode of euphoria, increased energy, and decreased need for sleep. Man, he's been partying. On examination, he's tachycardic, dilated pupils are noted, and he appears restless. Which symptom is more characteristic of acute intoxication with these substances? Well, that would be tachycardia. So, stimulant intoxication increases sympathetic activities. Psychomotor retardation is seen with the depressants. Hypersomnia is seen with sedatives, not stimulants, and the bradycardia is opposite effect of the stimulants. So stimulants equal tachycardia plus agitation plus insomnia. So yeah, they're stimulated. So heart's gonna beat faster, they're gonna be agitated, and they won't sleep. Which is the best first-line treatment for her condition? Benzos, SRIs, haloperidol, CBT only. A 35-year-old woman reports chronic worry about multiple aspects of her life for past 6 months. Right there tells you you're dealing with generalized anxiety disorder, chronic worry for 6 months. She has difficulty controlling her worry and experiences muscle tensions, fatigue, irritability, difficulty sleeping. Her symptoms cause social and occupational impairment. She has no history of panic attacks or phobias. Which is the first line treatment? First line treatment for generalized anxiety disorder is SRI. Benzodiazepine, again, are used for short term. There's a risk for dependence, so you're going to be avoiding that. Haloperidol is an antipsychotic, not indicated for anxiety disorder, and CBT only is effective, but SRI plus CBT is preferred for moderate to severe cases. So in this case, you're dealing with a chronic generalized anxiety disorder, uncontrollable worry, physical tension. We should do SRI plus minus CBT, but the question stem only asks for one, so it would be SRI. What is the most appropriate next step in management? IV haloperidol, oral benzos, naloxone, disulfiram. A 40-year-old man with a chronic alcohol use presents 12 hours after his last drink with tremor, diaphoresis, nausea, and anxiety. Vitals reveal mild tachycardia and hypertension. He has a history of seizure during prior withdrawal episodes. What is the most appropriate next step? Well, you're dealing with alcohol withdrawal, so you should give him benzodiazepines. Oral is the first line for alcoholic withdrawal. It prevents seizures and delirium tremens. Haloperidol may lower the seizure threshold, so it's not indicated here. Naloxone is for opioids, and dalferin is used for relapse prevention, not acute withdrawals. So alcohol withdrawal, think benzodiazepine first line. Which diagnosis is most consistent with her presentation? Anorexia nervosa, binge purge type, bulimia, binge eating disorder, body dysmorphic disorder. A 19-year-old woman reports recurrent episodes of eating unusually large amounts of food followed by self-induced vomiting, excessive exercise, and laxative use. Her BMI is 18, and she expresses intense fear of gaining weight. These behaviors occur at least once per week for the past 3 months and cause significant distress. Which diagnosis is most likely, and that would be anorexia nervosa, binge purge type, low BMI plus binge purge behavior. Bulimia usually will just have a normal BMI, not this low. Binge eating disorder is just an eating disorder. There's no compulsory behaviors, and the body dysmorphic, they'll be preoccupied with their appearance, has nothing to do with eating. So giveaway low BMI plus binge purge, anorexia nervosa, binge purge type. Which is the most appropriate management strategy? Psychotherapy with relapse prevention, hospitalization, antipsychotic medication, or just ignore. A 35-year-old man reports recurrent urges to expose his genitals to strangers, which he finds distressing. I bet they do too. He denies hallucinations or delusions. He seeks help to control these impulses, which have resulted in multiple arrests. Which is the most appropriate management step? So this patient needs psychotherapy for his voyeuristic presentation, sorry, not voyeuristic, exhibitionistic. So he likes to expose, voyeuristic he like watch. Sorry about that. I'm not trying to confuse you. So exhibit, show your stuff. Voyeuristic, peeping Tom. So first line for exhibitistic would be psychotherapy, focus on impulse control and relapse prevention. Hospitalization is unnecessary without acute risk. Antipsychotics not indicated, and ignoring while there is legal and personal risk persistent. So distressing paraphilic urges, psychotherapy first. Which is the most likely diagnosis? Social anxiety, panic, avoidant, generalized anxiety disorder. A 27-year-old man reports avoiding parties and professional meetings because he fears being embarrassed or humiliated. He recognizes that his fear is excessive, yet it significantly impairs work and social life. There is no history of panic attacks or generalized worry. So, if there's no history of panic attacks or generalized worry, we can rule out generalized anxiety disorder and we can rule out panic disorder. Symptoms have been present for several years, which is the most likely diagnosis. Well, he is fixated on his social events, so this is a social anxiety disorder. Panic disorder will be discrete, unexpected attacks. Avoidant personality will be pervasive, lifelong pattern of social inhibition, less of the situational, like in this stem. And the GAD, of course, is all about diffuse worry, not limited social stuff. So, social fear plus avoidance equals social anxiety disorder. Which diagnosis is most consistent? Body dysmorphic, OCD, anorexia, histrionic. A 32-year-old woman spends hours daily examining minor imperfections in her face and skin. She frequently camouflages perceived defects and avoids social situations. Her appearance is objectively normal. These behaviors cause significant stress and impair her functions. This is a clear case of body dysmorphic disorder. So she's checking her slightest little imperfections. OCD, it's all about rituals. Anorexia is preoccupation with the weight and shape, not with presentation here. And then histrionic is attention seeker, something completely opposite than what this patient is presenting. So minor perceived defect plus distressed body dysmorphic disorder. Which substance is most likely responsible for his presentation? Cocaine, heroin, alcohol, cannabis. A 45-year-old man presents with drowsiness, euphoria, and constricted pupils. His friends report a history of intravenous drug use. Which substance is most likely? Well, this is heroin. So you're going to have the opioid intoxication and drowsiness and euphoria. There will be all central nervous system depressions, meiosis, and euphoria. Cocaine is a stimulant which would cause tachycardia and a mydriasis and agitation. Alcohol is a CNS depressant but does not produce pinpoint pupils. So you can always tell by just what the pupils look like and point you in one direction or others. Is it an opioid? Is it cocaine? Is it cannabis? So alcoholism, there's no issues with pupils. If he has constricted pupils, drug use, you should be thinking heroin. Cannabis is euphoria without meiosis or severe drowsiness. So opioid intoxication, meiosis, and drowsiness. Which diagnosis is most consistent with his presentation? ADHD, bipolar 2, GAD, ODD. A 35-year-old man presents with a lifelong difficulties concentrating, relentless and impulsivity, causing problems at work and home, two different settings. Symptoms have been present since the childhood, so that indicates ADHD and occurs in multiple settings. He denies episodic mood swings or anxiety attacks. So, no mood swings, no anxiety attacks. Bipolar 2 is out. Generalized anxiety disorder is out. And oppositional defiant disorder is somebody who's a child, less than 18. This is a man that is 35. So, we're dealing with ADHD combined type. So, lifelong inattention plus hyperactivity, think ADHD. And our final question, guys, we're almost there. Which first line treatment is most appropriate? Antipsychotics, SSRI, benzos, and haloperidol. So, a 28-year-old woman reports repetitive intrusive thoughts of contaminating and spending hours daily washing her hands. This is OCD, and you should be thinking SSRI. She recognizes these thoughts irrational but feels compelled to act to relieve anxiety. The symptoms impair her social and occupational function. So, again, OCD, SSRI is the first line. Antipsychotics are reserved for treating resistant cases. Benzos are not effective in OCDs, and haloperidol is for antipsychotics, not the first line here. So I hope you guys like this video. Leave a thumb up. Tell me what you think. Did you like? I would really appreciate if you tell me if you like this video better versus the other one. We go question by question versus having you be timed and then go through the questions. That would really help me because I plan to make this video for all other EORs. Good luck on your exam. You're going to do great. As I always say, thousands of people have done this before me. I will do it too. That was my mantra during the school, and you will do fine. So I'll see you guys in the next video.